Yeah, can see.
Oh, okay, Ken, thanks. Okay, so hi, I'm Kao. I'm actually from the GSA and NEC in here in Changi, right? And what I want to share today is just a workflow that we had created, mainly as aimed at helping the junior doctors in managing hypocalcemia that happens after thyroid surgery. So what we're going to do is that we're going to share the workflow, but on top of that, we're just going to show you some of the hiccups that we've had along the way with hypocalcemia care, right? And the thought process that went into develop this workflow, right? I'm sure all of us have our own practices, right? And if it works well for you, fantastic, right? But over here, that because we had a couple of issues, right, we decided to put this into place so that we can make our patient care better. So just a little bit of background, right? I'm sure we all know that hypoparathyroidism, right, actually is a common complication that happens after total or completion thyroidectomy. Okay, obviously the rate is higher with a total, right, and it does not happen with hemithyroids because usually preserving one side of the parathyroid is actually sufficient to maintain the levels. Now, is this actually a common problem? Definitely it is, right? From papers, we actually have rates of 15 to 40%, right? But with all of this, and what I'll go through later is I'm trying to tie it all to our local population, right? To see how we can adapt what is known worldwide for ourselves. And even for us, right? Over a mini audit that we did over the last year, right? Our rates of hypocalcemia was about just under 30%, right? But of course, this is taking into account every patient who had any degree of hypocalcemia, even if it was low by 0.01, right? Even if it resolved within 1 or 2 days, right? As long as they had any degree of hypocalcemia, we included that into the rate, okay? So, I mean, of course, clinically, the rate is actually lower, right? Because we do have a few patients actually resolve within a couple of days, right? But it is still something that's common enough for us to pay attention to and to manage, okay? And it's not just the hypoparathyroidism that we are concerned about, right? What we are more worried, of course, is the sequelae of the hypoparathyroidism, right? Which would be the hypocalcemia, okay? Now, obviously, if there was a parathyroid hormone replacement, right, that would be the easiest management, right? Patient has low parathyroid levels, right? We give parathyroid and that treats it. Unfortunately, there are a lot of factors that come into account when we manage it, and it's not just about replacing vitamin D, replacing calcium. Okay, definitely the mainstay, of course, in patients who develop hypocalcemia, of course, would be to replace the calcium levels. Okay, right? This can be done orally, right? This can be done through intravenous route. On top of that, to aid with the absorption, right, we do need to supplement with calcitriol. Okay, so calcium absorption, as we know, occurs in the intestine, right? But for that to happen, right, it actually needs the activated version of vitamin D, which is calcitriol. Okay, without this, absorption is impaired. Okay, and why we do tend to give calcitriol is because the body usually needs parathyroid hormone to activate the enzyme that converts vitamin D to its active form, okay, which is calcitriol. Okay, so we have to take all this into account. On top of it, things that we do tend to ignore sometimes, right, will be the other electrolyte levels. Okay, and this does come into question, right, because magnesium and phosphate does have a significant role with calcium homeostasis. Okay, right. For instance, right, magnesium is actually required for the production of hypo-PTH and therefore calcium level. So if the magnesium level is low, right, this will further confound the hypocalcemia. Okay. Conversely, PTH is needed for the excretion of phosphate, right? So if these patients were to develop hypoparathyroidism post-op, right, patients may then develop hyperphosphatemia. Okay, so these are some of the many different factors that we take into account, right, when we decide for the management of hypoparathyroidism post-op. Of course, right, if it's just one standard route, one standard dosage, right, this makes life a lot easier, okay? But there are different doses, there are different prescriptions, right? Even for vitamin D, there are different analogs, right? So which do you choose? How do you choose? What dose do you want to give? So first step, before we actually created the workflow, right, we wanted to see, was that actually a problem, right? Because if there isn't a problem, right, why create more work for myself to fix something that isn't broken? So we actually had a look at it, and I think we identified three main issues that we needed to address. Okay, so first off was actually the junior doctors' experience or inexperience. Okay, so just to make it clear, I'm not faulting the junior doctors, right? But if you have not done time in GS, especially if you have not done a head and neck posting, you will not have been exposed to managing post-thyroidectomy patients. All right. On top of that, if you haven't passed through the head and neck team, right, and you only manage them as part of your on-call duties, right, obviously the number of patients that you will have to manage is low. Okay, and because if you're managing this by yourself, right, without any guidance, right, you may not know whether what you're doing is right or wrong, right? You see someone with low PTH levels, low calcium levels, you treat with what you think is correct, okay, but that may not exactly be the most ideal or optimal prescription, right? And unless you're vigilant enough to check back the next day on the patients if you manage, right, you may not realize that, hey, this could be better. Okay, even if you had spent time, right? Let's say the HO was not familiar and escalated to the medical officer. Okay, again, the medical officers do tend to rotate around quite a lot, right? And again, unless you've specifically been in the head neck team, right, you manage with what anecdotal experience that you may have had in the past. Okay, right? Even if you did know, right, like what we mentioned, right, there are many factors to take into account, right, when you manage hypocalcemia, right? And it's not just about correcting the calcium levels alone, right? There are other things that we talked about earlier, right? And we will go into a bit more detail later, right? Such as vitamin D levels and all that, okay? And speaking of that, right, vitamin D levels, right? We would assume that that should not be an issue, okay, especially here in Singapore, right? Again, I'm going to go a bit more detail later on, right? But it actually is higher than what we expect, okay? And I'm not sure about you guys, but personally for me, I am terrible at managing vitamin D deficiency, okay? So when we created the workflow, we took all this into account, right? Hopefully to address all these points, right? And to see what we can do and how we can do better. So again, just a little bit of a background. Okay, so this is what we used to do in the past. Okay, so whenever a patient comes in for a total or completion thyroidectomy, right, and we know that these patients are at risk of developing hypoparathyroidism, right, we do one serum PTH at skin closure, right? So that means for a patient still in OT. We do a set of PTH and corrected calcium approximately 6 hours after surgery. And then we subsequently do one every morning. Okay, so why do we do this, right? So the reason why we do this is because step one, PTH has a very short half-life of approximately about 5 minutes. Okay, so if there is any impairment to the parathyroid gland, okay, this should appear fairly fast. Okay, and routinely we let our junior staff close the skin, right? And sometimes the skin closure takes longer than the surgery itself, so the PTH levels should have dropped by then. Okay, calcium levels do not drop so fast, right? They will take several hours to declare itself. And this is why we usually do it another set about 6 hours after surgery. Okay. And then therefore, depending on the levels, we will train it usually every morning after the surgery. Okay. Now looking at this chain, okay, the most critical step that we found, okay, is at the 6 hours post-op bloods. Okay, and why this is because that usually the 6 hours post-op, it tends to be in the middle of the night, right? I don't know about you guys, but I am not so hardworking, all right? I will not stay back until 9, 10 o'clock just to trace out on the bloods, okay? So I will usually leave it to the on-call team, all right? And I'll trust them to manage accordingly, okay? But this is the issue because then, as I said, 6 hours post-op, there is usually a lack of senior staff guidance, right? But why are we so right, about doing the blood test early, right, about tracing out the blood test and wanting to correct any deficiency? Okay, so there has been numerous studies, right, that has shown that if you detect the hypoparathyroidism early, right, if you correct it early, right, it actually makes a significant difference to the patient. Okay, Unfortunately, what we don't have is a clear consensus on what is early, right? So some papers advocate doing it at the end of surgery. Some papers do advocate doing it once you reach the ward, right? But generally, the advice is that if you do detect and replace within the first 6 or 12 hours, right, there is a difference in the patient, okay? So again, we try to tie all this back to our local population, right? Because things may be different for other people in other countries, right? And this is just again from a mini audit over the last year of our patients, okay, or over the previous years of our patients. And we do find that using our regime, right, of checking the bloods immediate post-op, right, checking it 6 hours post-op and so forth, right? If we detect it early and we treat it early, right, there actually is a significant difference in the incidence of hypocalcemia, right? And even if it does happen, right, by starting calci trial and calcium replacement early, right, the severity of hypocalcemia is also lower. Okay, so I think this is strong enough evidence to show that we should try to detect it early and we should try to treat it early. Okay, and I think one of the most important factors for all head and neck or thyroid surgeons, okay, is we do want to try to avoid IV calcium replacement, right? Numerous reasons. One is that IV calcium can induce thrombophlebitis, okay? And thankfully, not my patient, all right? But we do hear cases of IV calcium extravasation, right? And IV calcium is very toxic to tissue, right? We do hear of cases that were just because of extravasation, the entire dorsum of the hand turns black and necrosis, okay? Right, so if we can avoid IV calcium, right, that is the most ideal, and that is the objective, right, of and that's the objective. Sorry, I just have trouble someone to turn off their microphone, right? And that's the objective of detecting and treating it early. Okay, so but why is this an issue at a 6 hours post-op, right? So as mentioned, right, I'm not as hardworking or diligent enough to stay back late, okay? And this is managed by the on-call team, right? Not that they don't know how to manage, but what we mentioned just now, right? Unless you've actually done time in the head and neck team, right? You may not be familiar with the protocol, the regime, or what we do, right? And again, they rotate frequently, right? So even if you have managed a few, you're just starting to get used to it, right? Come 4 months time, 6 months time, right? It's time for you to move on, and we get a new batch of junior doctors. Okay, right? Even if let's say you do get a senior MO or junior resident who encounters this, right? As of the moment, we don't really have a standardized regime, right? There are broad guidelines out there, okay? But right, I'm sure that the practice may differ between the specialists themselves, right? Whether it's from SGH or Changi, or even within Changi between GS head and neck and ENT head and neck, or even within GS itself, within the different surgeons, they may be different practice, right? So because you encounter a wide variety, right? A lot of junior doctors may not be familiar with which regime should I follow or what is best. Okay, right. So right, that is on assumption that they are not familiar, right? I mean, for all we know, right, they actually may not be an issue, right? And I'm just generating extra work for myself for no good reason. Okay, so what we actually did was we actually looked at our patients over the duration of 1 year. Okay, we looked at all the patients who had undergone total thyroidectomy or completion thyroidectomy. Okay, of course, the vast majority was those who had undergone total, with very few who had undergone completion thyroidectomy. Okay, from these patients, we looked at those who had developed hypocalcemia. Okay, we then looked at the management by the on-call team, right, to see when the bloods were done, what time they were done, right, when the medicine was prescribed, okay, whether the dose was correct, right, and whether the timing of the dose was given at the correct time. So over the course of a year, we had about 38 incidences of hypocalcemia. Okay, and I mean, I'm glad to say that the majority of them were managed adequately. Okay, but across the board, looking at the calci trial and calcium replacement, okay, actually just slightly over more than 20% could have been better. Okay, and this applies for calci trial and oral calcium. Okay, there were very few IV calcium that could be better, right? But looking at it a bit more detail, right, is actually more so because majority of the patients did not require IV calcium and therefore did not have IV calcium ordered incorrectly for the patients. Okay, so we'll be more focused on the oral calcitriol and oral calcium, right? Because I think 20% is still a significant number that we should try to address this issue. So what actually could have been better? Okay, so breaking down into different parts, right? What we looked at, number one was, let's say, did they forget to prescribe it, right? Was it prescribed correctly at a correct dosage, right? And one thing that we realized, right, was that there was a delay in the first dose. Okay, so again, just to backtrack, right, like what we already know and what there is evidence for is that the earlier you detect it, the earlier you start treatment after surgery, all right, the lower the incidence, the lower the severity of hypocalcemia. Okay, and what we realized was because that this a lot of this was managed after hours. Okay, what happens was that when the HOs ink up the medication on the computer on SCM, okay, they do ink it up as a BD dose, right? But what happens is that because this is really past the 8 p.m. Medication dispensing time, okay, the patients actually do not receive the medicine until 8 a.m. the next day. All right, so although the HOs did their duty, right, they realized that there was hypoparathyroidism, they inked up the correct medication, but because it inked up as a BD dose without a stat dose, the calcitriol does not get served until the following morning. Okay, right? Of course, a couple of times at the dosage, because I think they're not familiar, they try to err on the safer side and they ordered up a lower dose. Okay. Again, when we looked at calcium, okay, so there were a few patients, right, who did not receive oral calcium, although they should, right, means it was not inked up, okay. And again, for most of the patients, even if they did, the HOs did ink up the prescription, right, I think to err on the safer side, they do tend to order a lower dose of the oral calcium. Okay, so I mean, you might ask, why is that means oral calcium, right? Shouldn't it be clear that if the calcium levels are low, we should ink up the oral calcium? Okay, right? I will show you why a bit later on, right? And I think sometimes it's because they tend to interpret instructions verbatim. Okay, right? IV calcium, a couple of issues, right? So sometimes, although the calcium was low, they didn't ink up IV calcium, right? Or it may not be realized until the next morning when the morning team comes around, and then therefore they order the IV calcium. Okay. Again, no specific fault of the junior staff, right? But I think it tends to be because of misinterpretation of the post-op instructions. Okay. So what are the post-op instructions? Okay, so this was what we used to do last time, right? Okay, so for this was what we standard as a standard what we used to order for all our post-thyroidectomy patients. Okay, so once the blood tests are done, if they're out, if patients hypoparathyroid, right, then we advise them to replace the calcitriol and the calcium carbonate. Okay, simple enough, right? But then we start to have on and off issues. Was that because when patient was symptomatic from the hypocalcemia, or they had severe hypocalcemia, right? This was not treated, right? Because they've had the instructions there, right? No patients ready on calcium replacement, oral calcium replacement, right? They assume that should be sufficient. Okay, so we have times when the calcium was missed out, so we started to add this line to it. Okay, right? But what was the problem with this set of instructions, right? Again, because we don't have the stat dose, right? So that was when we had those issues where they ordered it, but again, because it was after hours and there was no stat dose, right? So the medication did not get served until the following morning. Okay, right. What was the next set of problems that we had? Okay, so then it was triggered 2 times. Okay, so the next problem we had was that we actually encountered a subset of patients, okay, interestingly enough, who had normal PTH values but had hypocalcemia. Okay, so because the previous instructions only accounted for hypoparathyroidism, okay, when they had hypocalcemia, this unfortunately was not treated. Okay, so PTH normal, calcium low, but no instructions, so they didn't treat it. Okay, this then triggered another set of problem, right? Was because that for instance, when the blood test and skin closure was done and there was hypoparathyroidism, okay, we gave one set of medication stat and ordered up the routine meds, okay. Unfortunately, when the bloods were done at 6 hours later, and the calcium was low, even it was slightly low, right? Then they will start to give another round of medication, right? When the stat dose was actually just given just a couple of hours ago, okay? So we then amended it again, okay, hopefully to try and avoid errors, okay. So unfortunately at this point we started to question ourselves, right? I mean, if this were to continue, right, the post-op notes may actually end up longer than operative notes itself, okay. So we decided, you know, maybe we should look at it to see how we can do better, right, at passing the instructions downstream, okay. So, right, I mean, that addresses the junior doctor's experience or lack of familiarity with management, okay? But I mean, let's say, right, we do have a HO who's particularly diligent, right, who knows when and where to look for answers, right, rather than those who just study for the exam and then vomit everything out and cannot apply, okay? So what if we do have the on-call HO who is quite diligent and decides to go look up, no, let me see what the guidelines are, right? And I will follow the guidelines and treat it according to international guidelines. So we fall back to our gold standard, right, of what we look at, right, the American Thyroid Association, right, which has come up with hundreds of pages of guidelines, okay, and this is their recommendation, right, for managing hypocalcemia after thyroidectomy, okay. So, I mean, just looking at it, a couple of points I think just to pick up, right, is that, I mean, of course, right, in the middle of the night, right, when you're tired, you're swamped, right, looking at this, it may make it it's not so easy to interpret for you to decide what dose and how you want to correct it, okay, right. And couple of things, of course. One is the dose, especially for oral calcium, is slightly different from what we have, right. So over there in US, they have the calcium carbonate does come in 1 gram, 2 gram tablets, whereas for us, it's usually in multiplies of 1.25. Okay, so dosage is slightly different. Two is that the units they use for calcium level is again different from what we use. Okay, so obviously, you know, if you do interpret it directly, 8.5 is very high if you do not convert it. Okay, so then this comes again, it's not as user friendly for our local population. Okay, right. I think calcium trial should be quite safe if you stick with the middle line. Okay, calcium carbonate, again, you have to use your own interpretation to decide what you want to use for it. Okay, right. I'm just going to detour a little bit, right? So the other guideline that is available, okay, if obviously from the UK as well, okay, and this is I've actually lifted it directly from their workflow, okay, right, and helpful, right? I think you can follow the arrows to see what it is, okay, but then again, right, the medication they do use is slightly different from what we do use, okay, and just to highlight, they use calcichew, 1-tap QDS, right, which works up to about 2.5 grams BD, okay, or about 5 grams in total in a day. Okay, right? But this is their recommendation, right? We could follow this, right? But it's again, it's slightly different from what we do. Okay, so we're going to fall back again to ATA, right? Which is what I said we usually tend to use as our reference point. Okay, and this time I've converted it to make it a bit more applicable to our local population, right? So the values have been adjusted for hours. Okay, and this is actually the recommended total oral calcium replacement in 1 day, right? And it's usually given up in divided doses throughout the day so that you can maintain a steady plateau of serum calcium levels. Okay, so, right, is this useful for our population again? Okay, so what we did again was we looked at our own population over the course of a year, right? And what we looked at was what was the oral calcium carbonate discharge dose. Okay, so basically what they need at the end after everything has plateaued, right? Okay, of course, during the stay, they may have had a higher dose, they may have had a lower dose, right? But this was the subsequent final dose that was given to them on discharge, right? And looking at looking at a snapshot of this, right? It does look that our population actually requires a higher replacement regime, right, than what is used in the United States. okay? And it, even the lowest discharge dosage, okay, is really higher than the highest recommended route from ATA, okay, right? But where does it actually stand? I mean, looking at the median dosage, right, for patients with mild or severe hypocalcemia, right, we find that our patients usually need about 5 to 7.5 gram a day, right? Meaning we usually give about 2.5 gram BD or Q8 hourly, okay, right? So the problem with this is that if the night staff, right, on-call team reverted to ATA, right, it officially means that most of our patients will still be undertreated. Okay, if not all, okay, it will be undertreated. Okay, right? So interesting, right? Why do our patients actually need more calcium, right? What could the issue be, right? So could it be because of vitamin D deficiency? Okay, you may question, right? I mean, vitamin D deficiency, vitamin D is usually made from exposure to the sun, right? And we know Singapore is definitely has more sun than a lot of other countries in the world, right? It's so hot right over here that we complain about it all the time, right? So do we actually have vitamin D deficiency in Singapore, right? Unfortunately, we do, right? Because it's too hot, right? Because of the Asian thought that the fairer you are, the more pretty you are, right? Or even people like you and me, right? We come to work before the sun comes up, we go home right after the sun goes down, right? The only radiation we get is whatever we get from II in OT. Okay, so vitamin D deficiency actually is a lot more common in Singapore than what we would expect. Okay, and these are just some of the local papers that are pulled out, right? Of course, they look at different things, right? Whether it's from osteoporosis, geriatrics, and so forth. Okay, right? But what they did find was that more than a third of us, okay, actually do have vitamin D deficiency. Okay, right? It may not be apparent, right? We may still have normal calcium levels, okay? But definitely more than a third of us, right, do have vitamin D deficiency here in Singapore, despite there being so much sun, okay? But does this actually tie into our patients? Does it actually affect our patients, okay? So again, right, we're looking back at our own patient population again, okay, over the course of 1 year. And this time what we looked at, right, was we isolated patients with hypocalcemia. Okay, so this is only patients with hypocalcemia. And we then compared the PTH value, okay, and the vitamin D levels. Okay, so looking at this graph, okay, we will exclude the purple box, right? Purple box were for those patients who did not have vitamin D levels perform. Okay, so if you look at the blue and the orange box, okay, so in the first, on the left side, what we have are patients who are hypocalcemic and have low PTH levels. Okay, and 75% of them had concurrent low vitamin D levels. Okay, right? Could this be a confounder? Perhaps, right? But we already know that in this population, the incidence of low vitamin D, right, is already higher than the normal population, right, which was approximately about 30%, right, compared to this group, which is about 75%. Okay, right? How about in the next group, right? So these are patients who develop hypocalcemia post-op, but had normal PTH values. Okay, right? Again, if we exclude the purple box, okay, and we look at the remaining 7, okay, so of those 7, so these are 7 patients with hypocalcemia and normal PTH levels, okay, they all had vitamin D deficiency, okay, which I think is strong enough to suggest that vitamin D, right, in our patients, right, will affect the incidence of hypocalcemia post-op. Okay, and therefore this is something that could be managed. Okay, so with this, I think it's quite clear cut. There are already established routines for treating vitamin D, right? And what we just did was we adopted into our workflow, which I'll show you later on. Okay, right? Do we actually need to replace it? I think the answer is yes. Okay, right? Because there are multiple papers out there that showed that replacing vitamin D, either pre-op or early post-op, okay, again, right, it reduces the incidence of hypocalcemia, right, and if you do develop, right, it is also less severe. Okay, right. Now of all this, okay, unfortunately, the regime are all different. Okay, some actually start 1 week pre-op, some start the day before surgery, right? Some start on the day of surgery itself. Okay, so they're all different regimes, right? And unfortunately, even the choice of vitamin D analog are different as well, right? With some giving cholecalciferol like what we use here, some give a pre-op alpha calcidol or even a pre-op calcitriol. Okay, and unfortunately, of all these 7 papers that I picked up, okay, only 2 actually looked at the vitamin D levels. Okay, but those 2, one did not show any significance with the hypocalcemia rate. One said that vitamin D deficiency does worsen the hypocalcemia rate. Okay, but what they all do agree is that if we do correct the vitamin D, they are less likely, right, and to get hypocalcemia post-op. Okay, so this is what we should. Okay, so taking into account all this, right, so a few of us decided to come up with a workflow, right? So we try to be as inclusive as possible, right? We do believe it is important to work with people from different specialties, right? Because we should be one big happy family, right? So there's myself and Prof. Adrian Koh. We also work with endocrine, okay? And from the Changi ENT side as well, right? So after a discussion, we came up with a workflow protocol. Okay, so we've come up with a 2-page workflow. Okay, and I'll zoom in to the smaller parts for you guys to have a look at it. Okay, hopefully that this will be a useful guide for the junior doctors in managing it during their night call. Okay, so of course the first part is very generic, right? These are the bloods that are usually done at PAC. Okay, what I'll just draw attention to, okay, with not everyone might do, is that we will also check the corrected calcium levels as well as the vitamin D levels. Okay, I have to confess that this does not always happen, right? Because especially in the younger patients, PAC may not do the bloods for the patient because they do not require it. Okay, what we do then is that we keep an eye for it. So upon admission, okay, when the anesthetist set the plug during induction, right, we will then draw the blood at that point, right, to do the blood test. Okay, why we try not to do it in clinic itself is mainly just because we're trying to minimize poking the patient unnecessarily. Okay, we don't want to poke the patient once in clinic, right? Poke the patient the second time in PAC, right, and then poke them again on induction. Okay, so if it can be done at PAC, excellent. Okay, if not, right, the backup will be to check on when the patients admit, right, and to do it at induction itself. Okay, right. This part is absolutely helpful for me, right, because I have no idea how to manage vitamin D deficiency, right? Even if I did, right, I will not be able to remember all the different dosages and all the different regime. Okay, so having it all concise and placed in a very nice, easy, accessible manner, right, I think helps me a lot. Okay, so I find this is very helpful for me. Okay, of course, we also put a caveat down there in patients with CKD or ESRF, right, who already have secondary hyperparathyroidism. Okay, obviously the management and the calcium vitamin D levels are haywire. Okay, so we would actually get our renal colleagues input for this. Okay, and at the bottom of the first page, right, again, just a recommendation, right? What we do have is that immediate post-op is to follow the flow chart, okay? What we usually do every morning, right, will be to monitor the bloods, right, namely the IPTH and the corrected calcium, okay? We also monitor the magnesium and the phosphate if necessary, okay? As a reminder, right, because I said I myself I'm not very experienced with managing vitamin D deficiency, right? We do have a reminder to make sure that vitamin D levels have been checked, right? And that we are correcting it according to the table, okay? But I mean, among all of this, I think what is the most important or what is the most useful, right, is the reminder to follow the flow chart, right? Because again, this is targeted for our junior doctors who have not had the chance or the experience to manage these patients, okay? So, right, what do we recommend, right? So we first look at the first step, right, which is the immediate post-op IPTH, which is usually done at skin closure, okay? So the best route is that, of course, everything is normal, right? Normal, right, we will still check 6 hours post-op, right? We still check the following morning. However, if it's persistently normal, right, we will stop, okay? Why still check the corrected calcium, right? Assuming that PTH is normal, why check the corrected calcium? Okay, because as what we highlighted earlier, right, we do have a substantial number of patients who have vitamin D deficiency, right, who will still develop hypocalcemia even with a normal PTH value. Okay, but if all's normal, all's good, all stop. But what if the immediate post-op PTH is low? Okay, so of course, yes, we still need to monitor the bloods because then they are more likely to develop hypocalcemia. Okay, and then we have the recommended dosage or what we usually use over here. Okay, which is our calcitriol, stat dose, and of course the regular dose. Okay, so then moving on, right? So then if they do develop hypocalcemia, right, what do we do? Okay, so then again, there's a reminder there, right, to monitor the electrolytes and what we discussed, right? They can develop hypomagnesemia, they can develop hyperphosphatemia, right? So that needs to be corrected. Okay, again, something that we tend to forget or we may not associate with thyroid surgery, right, of course, will be the vitamin D levels. Okay, and that's important to check out on that, right? And also as a guide, right, with hypocalcemia, they can get prolongation of the QTC interval. Okay, so a reminder to perform an ECG, right, to look out for that. So what if the corrected calcium levels are low? Okay, so basically we want to separate them into two main groups, right? Are they symptomatic, right? Or severe hypocalcemia, right? Or just mild hypocalcemia. Okay, so if it's still within normal values, right? So 2.1 to 2.2, okay, we will still recommend starting an oral calcium replacement. Okay, because if they were hypoparathyroid, right, they are very likely that they will develop hypocalcemia sooner or later. Okay, and as mentioned, right, the earlier we treat, the better it is for the patient, right? And our main objective is to avoid the need for IV calcium. Okay, so if it's hypo-PTH but normal calcium, right, we still should start them on an oral calcium replacement, but of course at a lower dose. Okay, obviously as the hypocalcemia worsens, okay, then we do need a higher dose. Okay, and this is what we would recommend starting with. Okay, again, this is based on what we looked at in our own local population, right, and what the discharge dose tends to be. Okay, and that's where we come up to this regime. So let's look at the sicker patients. All right, so those with severe hypocalcemia, meaning those with less than 1.9, okay, or those who have developed symptoms. Okay, so mild symptoms, or what we usually tell our junior staff, will be things like paresthesia, tingling, right? Severe symptoms of hypocalcemia include those of muscle spasm, tetany, or ECG changes. Okay, so if it's mild calcium, mild symptoms, or just biochemistry hypocalcemia, okay, the recommendation is, of course, to give an intravenous route. Okay, and of course, this needs intravenous because the action is faster. Okay, we place this here because the route, the dose that we give, right, would be different from what the junior staff may be comfortable giving, right, especially in context of hypercalcemia or whatnot. Okay, they do need a higher dose of IV calcium replacement. Okay, again, as we said, we like to work with all our colleagues, right? So if patients have severe symptoms or very severe hypocalcemia, right, we will get endocrine colleagues involved. Okay, and we actually do have another set of protocol which we created in the past, right, to guide IV calcium infusion. Okay, so this is a continuous infusion. Okay, but to keep this concise, we did not include a table with this set of workflow. Okay, right, on top of this, because we do not want to give IV calcium persistently, right, now that's why we move on further down the route, right, is which patients will still need oral calcium replacement. Okay, right, and then depending of the severity, right, then we will then monitor the corrected calcium levels. Okay, so for this we will not have a set duration because it will be very, very variable. Okay, so this will be a judgment call, right? And subsequently down the line, of course, again, is a reminder to replete the magnesium and phosphate levels. Okay, right? We do recommend not replacing phosphate with the same line as LV calcium because phosphate binds very readily to calcium, right, to form calcium phosphate and debris, right? So not to give at the same site. Okay, so right, we've made the workflow, right? And obviously because I'm biased, I created a workflow. I would say that this is the best workflow in the whole world. Okay, so what we actually did was we opened it up as a survey to the junior staff, right? I may think it's good, right? But they are the ones who are using it. They are a better place to give input on this workflow. Okay, so we had a small survey just asking about 4 questions. Okay, and we start off with asking prior to using this workflow, right, how comfortable were they in managing hypocalcemia in the post-thyroidectomy patients? Okay, and then following on, of course, right, how comfortable are they using the workflow? Okay, and because the workflow has many branches and so forth, right, how difficult is it for them to interpret the workflow? Right, and the last question is, would they be likely to use this workflow when they manage hypocalcemia? Okay, conflict of interest. All right, I do buy my junior doctors coffee and food every morning, right? So of course the answer might be a bit more biased as well. Okay, right. But looking at it, okay, so this is the scores that we have, right? Before using the workflow, right? 0 is being not comfortable in managing hypocalcemia. Okay, 10 being that they are very comfortable. Right, and expected, right, if you look across the years of experience, right, the more senior you are, obviously the more comfortable you are in managing hypocalcemia and hypoparathyroidism. Okay, right, but if you look at the blue box, which is the house officers, right, who will be the main bulk of the team managing it after hours, right, most of them have not had much experience in managing hypocalcemia or hypoparathyroidism rather. Okay, right. So we then look based on the workflow, right? And I'm glad to say that there actually is improvement in the score, right? Across the board, most people, most of the junior staff feel a lot more comfortable in managing it once they have this workflow to refer to. Okay, and I think there's quite a significant jump, especially at the house officer level, right? Which again will be the main group of doctors who will be managing these patients. Okay. So can be confusing, right? I think the first draft that we actually proposed was actually quite difficult to refer to and to understand. Okay, and I'm glad to say that with the new draft, most people do find it easier to follow. Okay, right, and just to show that it's not adjusted data, right? So there were some people, or rather one person, who might not have referred to the workflow. Okay, but I think most people are actually quite happy to use the workflow to guide them in the management. Okay, right. So just want to thank you all for spending the morning with us, right? Just to run through this workflow that we've actually put into place. We've actually only just created it over the course of the end of last year, beginning of this year, right? And we've now put it into use within our team itself for the house officers to refer to and to use. Okay, right. I just want to open this to the floor to see if anyone has any questions that they would like to ask.
Yeah, thanks, Carl, for the enlightening message. It's very good to see there's improvements. There's some caveats, I'm sure, with the regular coffee buying, which may alter the legitimacy of the results. But I think it's clear that a guideline will be useful, at least for our junior doctors. And I'm glad that we have something that they can follow, so that we can avoid unforeseen circumstances for our post-op patients. Happy to take any questions in this time. We can either just unmute and ask, which would be great, or we can also type in the chat and then we can respond to the chat live as well.
Hi, morning. Thanks, Dr. Carl, for the wonderful presentation. I'm Nyam from NUHS Endocrine Surgery. So we have some experience in running these sorts of protocols. My question to you is, how do you, is there a follow-on protocol after the patient is discharged?
Yeah, okay, Ken. So that's actually a good question. So as of this moment, we actually don't have a fixed protocol for what we do after discharge. What we do in practice, okay, at least for us, we have a few routes actually. So if these patients were already known to endocrine before, okay, so meaning they were referred to us from endocrine, what we actually can do is we actually do have a pharmacy-led endocrine clinic, right, that we will send to them fairly early post-op, so usually in about POD 5 or so, right, to monitor the calcium levels and to adjust accordingly, right. For those who do not or are not known to endocrine, right, we unfortunately cannot make use of this resource. So what we usually do is that we will make a special arrangement, right, because unfortunately our clinic will be usually about 1 week post-op or so, Okay, so we usually make a special arrangement for them to come back to monitor the calcium levels, right? And to adjust accordingly. Okay, now the practice does differ. Okay, but in general, what we try to do is that we do try to so along following the lines of the Atlanta regime, is that we do try to slowly cut down the dose weekly or so, 1 or 2 weeks or so. Of course, first is we try to wean off the calcitriol. Once the calcitriol above the lower limit of normal, okay, and then the calcium levels we will gradually titrate down. And what we aim at is actually for slightly low, right, or at the lower edge of normal. Meaning we usually aim for about 1.9 to sorry, aim for about 2 to about 2 to 2.1. Of the corrected calcium levels, okay, and this because we know that if you have a slightly low calcium levels, this actually will stimulate the body to produce more PTH, right, and therefore this will aid with the recovery of the hypoparathyroidism. Okay, so the follow-up is not fixed. I mean, definitely we do have our early special arrangement, right, but therefore the reduction in the calcitriol and the calcium unfortunately is still very patient dependent, based on the calcium levels and whatnot. So we do not have a fixed protocol for that. Right, I hope that answers your question.
Yeah, so it's seen by endocrinology, right? This patient.
Only if they were known to endocrinology before this, right? But if let's say we get our patients who are referred directly to us from polyclinic, right? Then those we manage it ourselves.
We find any issues trying to balance this management because our issue is that sometimes there's some discoordination between the two.
Yeah, so some issues that we had in the past was, I mean, sometimes was this special arrangements. So unfortunately, these special arrangements may happen on a day where we've got other clinical duties, right, such as scopes, etc. And what we have had in the past was that the patient came for the blood test, right, and because it wasn't a formal clinic, the clinic assumed it's just for blood test, and then they discharge the patient after doing the blood test before the results are out. Right, and then what happens that we have to remember to trace it up, and if it's low, then we have to call the patient to readjust the medication. So I think those are some logistics hiccups that we've had. The other issue, I mean, small issue is that because we have operating days on Monday and Wednesday, so for the patients who have the surgery on Wednesday, POD5 usually falls on about Sunday, right? So we then will follow up with them on Monday instead, which is slightly late, but I said there's just a minor hiccup, right? But there's just some of those, these logistics things that we face.
My last question, since it's a surgical forum, any discussion about parathyroid preservation techniques during surgery?
Yeah, so I think that's pretty standard for all thyroid surgeons, right? So of course, the main thing is that we should identify the parathyroid, because by identifying it, we actually will be able to preserve it. But patients actually develop hypoparathyroidism, right? It's more because of disruption of the blood supply rather than inadvertent removal of the parathyroid gland, right? And this happens is because the thyroid gland and the parathyroid glands share a common blood supply, right? Majority of it comes from the inferior thyroid artery. And what we do is that when we dissect or ligate the blood supply, right, this does tend to get cut off, right? On top of it, right, the output, right, so the venous output for parathyroid, when we peel the parathyroids off the thyroid gland, the venous branches, which tend to be quite small, do tend to get disrupted, right? So all these parathyroid glands do tend to get some form of ischemia, right? And it's because of this reason, that's why the large majority of hypoparathyroidism is transient, right? Because parathyroids are robust, even though they turn ischemic, they will revascularize themselves, right? And therefore, the hypothyroidism resolves, okay? So important, number one is, of course, identify, preserve, right? Gentle manipulation. Try to preserve the blood supply if possible, okay? But again, that is not always doable.
Thanks, Nyam, for the question. Clement has a question on the chat. Thank you for a nice nice talk on this topic. What do you think about doing vitamin D levels and correcting it earlier pre-op, 2 to 3 weeks prior instead of a day of admission? And do you think it make a difference to post-op calcium levels?
Yeah, Kevin. So I think that actually is a very good point. So I think in ideal world, I think that will really help a lot. So I mean, in the studies that we looked at, those are correcting it pre-op. A lot of them do try to treat it about 1 week before the surgery. Okay, but this is probably something we need to look into because, like we said, we also try to minimize poking the patients. And what happens in our clinic is, of course, when the patients first present to us with any thyroid nodules, right, as part of workup, we will poke them once for the thyroid function test. Okay, assuming then they've gone for the workup, the FNA, and then they come back for surgery, right? If we were to do it at clinic at that point, right, to check the PTH, the calcium, vitamin D levels and calcium, right, means we poke them a second time in clinic, right? And then subsequently at PAC, right, which can be about 1 week before, right, then we have to poke them again, right? And of course, when they induction, they do get poked the second time. So I agree with you in if we can come up with a ideal plan or that identify early, treating the vitamin D deficiency early, right? I'm sure it will make a big difference to the hypocalcemia rate. But I think it's just a balance of trying not to poke the patients too many times.
Thanks, Carl. Any other questions from anyone else from the floor? Okay, I think if not, I think I would. It's almost times. It's 8:55 already, so I will not prevent people from getting their vitamin D today in the sun. I hope that you have a good weekend coming up, and thank you very much, Carl and your team for the talk today. Of course, we are always happy to answer or discuss more, I suppose, within the head and neck endocrine community. How we can improve things, especially post-operative management, especially for junior staff, so that we all can work together to improve things. So thank you very much. Thank you everyone for your time, and have a good weekend ahead. Thank you.
All right, thanks everyone. Thank you.